I'm Tony Leeds. I chair the TDMR Europe organization, and it's my great pleasure to welcome you to this web seminar in which we're going to look at the role of total diet replacement in achieving an initial weight loss in a number of conditions, and then the issues that relate to achieving longer term weight maintenance. If we go to the next slide, please. And just a few points about how we're going to run this. If you have any questions during the course of the presentations, if you would type them into the Q&A option at the bottom of the page, we'll then try to address as many of them as we can, maybe one or two at the end of each presentation, and then more of them at the end when we have 5, 10, or 15 minutes for further discussion. If you have any technical problems during the event, we've given you an email there, which you may wish to make a note of now, and then send a note in if you have a problem. Okay, may we go to the next slide, please? And you should know from the emails that you received, because we did send you the abstracts and biographical notes, there are 4 of us participating today, but the main presentations will be from Nerys Astbury from the University of Oxford, from Jennie Brand Miller from the University of Sydney in Australia, and Michael Lean from the University of Glasgow in Scotland. Next slide, please. And then when we complete that, we'll have a very short presentation discussion based on your comments. To begin with, I'm going to just make a few very brief comments about total diet replacement. Just by way of background, I am a recently retired bariatric physician who had worked in the NHS in England, and I now, as a semi-retired individual, also have visiting posts in Copenhagen and in Glasgow. And I'm just now waiting to get my slide to move forward. Right, good. So this is what I'm going to cover, the amounts of weight loss that can be achieved with total diet replacement. And I'm going to begin by telling you that these are my disclosures. I was medical director of Cambridge Weight Plan until 2.5 years ago, and now chair the industry group. And I'm going to consider definition. What are we specifically talking about? The amounts of weight loss. Refer to the American endocrinologist guidelines, which were issued a few years ago, which are a useful set of figures to work on. Consider the issue of whether TDRs are safe, and then some comments on weight maintenance. Total diet replacement is a description that is used for dietary programs which consist of formulated products and do not include conventional food. These can be presented as soups or shakes or bars or other fruit products, but the key thing is that they provide a reduced amount of energy along with sufficient protein, essential fat, and micronutrients. Low energy liquid diets are 800 calories or above. Very low energy diets are, by definition, those under 800 calories, and we're usually referring there to 600 calories per day. That might be delivered in 3 portions. The LED diet, the one above 800, can sometimes be delivered with 4 and sometimes 5 portions. In some situations, of course, individuals have undertaken randomized trials where there's been a supplementation of the total diet replacement with some additional, for example, non-starchy vegetables. That has been done in a number of trials. These are low carbohydrate, but they are not, strictly speaking, very low in carbohydrate because they provide 60 to 80 grams within the 600 to 800 calories per day, and the protein content is 60 to 80 grams. The consequence of using this type of diet, of course, is there's a larger energy deficit between what you're actually delivering in the diet, provided there's compliance with the diet, and the requirement. And as a consequence, there are greater weight losses. And the middle of the range values that are usually seen are somewhere between 1.3 and 1.5 kilograms per week after the initial fairly rapid weight loss that occurs in the first week or so. One of the interesting observations is that the compliance with this type of diet is generally, at least as shown in the randomized trials, fairly high. For example, in the first 8 weeks of the preview trial, compliance was 91%. As far as mechanisms are concerned, there's much to consider and much to discuss, but it does seem to be that the raised blood ketones may well have an effect in suppressing the rise of ghrelin. However, there's very little experimental work in this area and much more needs to be done. So mechanisms can be discussed. You move on to the next slide. Sorry, the system seems to pause a little here. So first of all, the American Association of Clinical Endocrinologists paper, an extensive document which reviewed the evidence up to 2016, in which they set some guidelines for clinicians in terms of the management of obesity. And it's interesting as you look through that, and I've just selected out these figures from their tables, how 5 to 15% does occur frequently, and certainly at least 5% for some conditions. You'll see that for pre-diabetes, a recommendation of a 10% weight loss to prevent diabetes. And for many people, that might be of the order of 10 or 15 kilograms weight loss. And for type 2 diabetes, to achieve remission or medication dose reduction or improve control, the range of values they suggested might be 5 to 15%. Mike Lean will expand on this later and will be suggesting a target value of 15% probably. For hypertension, again, up to 15%. Non-alcoholic fatty liver disease, if a 5% weight loss might deliver a reduction of liver fat, it may well be that greater amounts of weight loss are needed to achieve reduction of inflammation. Not a lot of experimental work has been done in this area, so we have to await the work of other individuals. I'm now going to choose a couple of examples of trials which are not otherwise going to be referred to later in the afternoon to illustrate the amounts of weight loss that can be achieved. So this is an example from some work done in Sweden on obstructive sleep apnea in men with obesity, so it's severe and obstructive sleep apnea. These men used a 600-calorie diet for 7 weeks, and you'll see that they achieved a weight reduction of 18 kilograms, and importantly, an improved sleep apnea state. This was a randomized controlled trial in which those who were on the waiting list during the course of the first phase were then subjected to the weight loss program, and then all were followed for a year. So this is an example of the great amounts of weight loss that can be achieved. Compliance was good. This was done in the obesity unit at the Karolinska Hospital, so it's an intensely managed by dietitians setting with frequent interactions between the healthcare professionals and the individuals taking part. And then another trial that was undertaken that was actually started in 2007 on elderly people with obesity and knee osteoarthritis in Copenhagen, in which in the initial phase, you'll see in the figure there, the first 8 weeks was either a very low calorie diet of 415 calories or a low calorie diet of 810 calories per day for 8 weeks. And that delivered weight losses of 10.7 kilograms on average in the low calorie diet and a little higher, 11.4 kilograms in the VLCD. Those individuals then, there was food reintroduction, taking them up to about 1,200 calories per day, and then they went on to some long-term maintenance programs. And then the final observation here is that, of course, there is enormous individual variation in the amount of weight loss that individuals achieve. And when you look at the papers and the results, you're seeing the average value and not the quite wide range of values that occurs. This is one of Mike Lean's figures from 2013, when a feasibility study was undertaken prior to the commencement of the direct trial that he will describe shortly. And you can see from that figure that these individuals who were quite heavy, they weighed on average 131 kilograms, lost 10% of their body weight in 8 weeks. But you will see scattered around that, each of these lines is the individual weight trajectory. There's quite a wide range of responses, and that happens in all trials, but of course you don't actually see that in the publications. Are total diet replacements safe? The main concerns are initially, from a practical point of view, the minor adverse effects, constipation and dizziness. I'll come to some figures in just a moment. And then people are also concerned about whether or not that you might precipitate gout in susceptible individuals, and whether some individuals may have acute gallstone episodes. There are also some concerns about lean mass loss. And of course, there are adaptations to the resting metabolic rate, which are normal physiological responses, but they may have important effects, and therefore one want to protect lean mass loss. So first of all, if we look at the preview results, now this is the largest data set on individuals who have used an 8-week total diet replacement to achieve an initial weight loss of up to or more than 8% in body weight, over 2,000 individuals. And you'll see that the most frequent adverse effect was constipation, and then a muscle weakness or fatigue, and then headache and dizziness. The constipation, certainly in my practice in London, we usually address by an initial discussion, and those who are predisposed to gut or large gut related problems, we might overcome this initially by giving them an additional dietary fiber stool bulking supplement. The dizziness is important. Mike will probably discuss this in relation to hypertension, and of course an individual who is being treated for hypertension, we have to be very careful, particularly in the elderly, because a rapid reduction of blood pressure sometimes occurs, and of course there may well be episodes of postural hypotension if this is not anticipated. So dizziness can be a possible problem. Gout. Now, there are concerns about gout, and in the preview trial, there were 6 cases, but in men only, as you might expect. So the frequency was not particularly high. And interestingly, in the preview trial, there were no gallstone events, although the work done by Kari Johansson in Sweden, where she reviewed over 20,000 cases of treatment with VLCD or low-calorie diet, might have suggested that 6 cases might have been expected, but there were no reports. So maybe gallstones and gout are less common than we expect. And these are figures from the droplet trial, and Nerys will also show these figures a little bit later on. And again, constipation, fatigue, headache, and dizziness were the main minor adverse events. And it's obviously important to advise individuals that there is a possibility that these things may happen. And then we come to the question of lean mass loss. Now, if you look through the papers, you'll see a very wide range of values quoted, from quite high values where individuals are very high BMI and then lose weight very rapidly, through to quite low ones. And I've just chosen one example from another trial that is rarely referred to, which is a trial on women who have had coronary heart disease and are in a secondary prevention program. This was undertaken in Copenhagen on 70 people, 70 women who were non-diabetic, who were weight over 28, BMI 28, and they were randomized either to an aerobic interval training program or an 800 to 1,000 calorie diet to begin with for 8 to 10 weeks. And then at the end of that period, all of them went on to the aerobic interval training program. And I've just picked out the figures in relation to weight loss. The top there shows you that the weight change at 12 weeks in the low energy diet, the formula diet program, was about 10%. A weight reduction of a smaller amount in the training group. Lean mass loss is shown in the next panel, that it's aerobic interval training. They gained a little lean mass. In the LAD group, they lost some, but surprisingly, it was quite low at 6%. And then if we go down to the bottom and you look at lean mass, where all of them have undertaken this fairly intensive aerobic interval training for a year, you see that in actual fact, the amount of lean mass loss is about 7%. And this is very low compared to other trials, such as the osteoarthritis trial, where the figures range from 11 to 17%, and other trials where there's figures at high levels of about 20% or maybe 25%. And then finally, a reference to a paper that was just published on the 18th of October. And I do know that some of the authors of this paper are participating in this meeting at the present time. And this was a randomized trial to investigate the importance of protein in the diet. At the moment, this type of diet provides 50 to 70 grams of protein, depending on the actual energy intake. But this was specifically a 600 calorie diet with 52 grams of protein compared to 700 calories with 77 grams of protein. You'll see the weight loss is there slightly less when the energy intake was high. The top line there, weight loss 13.3 compared to 11.5. If you look at the lean mass loss, you'll see that it was 3.6 compared to 3.2. They also measured resting metabolic rate, and there was an adaptation of that, so a reduction of resting metabolic rate. Very slight difference between the two. But the importance of this observation, this trial, is that adding on an extra 25 grams of protein seemed to have little effect on the amount of lean mass loss. And the importance of this is, of course, that there is an expectation that there will be a requirement for total diet replacement composition to change to the higher protein level in October of next year. But this experimental evidence published a week ago does not tend to support that. And then we come to the question of maintenance. And now this is the 1-year set of results for the obstructive sleep apnea study that I showed you earlier on, study from Sweden. You'll see the weight reduction, it's the blue line, down to nearly 20 kilograms, and then maintenance, again, intensively managed for a year, and something of the order of 15 kilograms weight maintained up to 1 year. And the importance of this, several points are important here, is that this is a study on obstructive sleep apnea, which occurs commonly in people with diabetes. It raises high blood pressure, is a factor in the causation of stroke. Not everybody, of course, who has obstructive sleep apnea is necessarily heavy, but this shows, along with many other papers that have been published before that and since then, that a good weight loss can actually make a huge difference. And in this case, 10% of the individuals no longer were affected by obstructive sleep apnea afterwards. And also, interestingly, those who had the most severe sleep apnea or who lost most weight were the ones who benefited most. So this is a study which has actually been lost and seems not to be followed, but it needs to be followed up in the fullness of time. I'm trying to move to the next slide, which refers to the osteoarthritis trial and shows you 3-year, when it does appear, it will show you the 3-year results. That's it, good. So what you see here is a panel which shows you the 3-year maintenance, weight maintenance results in the 153 individuals in total who participated in a 3-year maintenance program. What you see there is that the higher line represents the delivery of 1 meal replacement per day throughout the whole 3-year period. And the bottom line represents an intermittent delivery of an 800-calorie total diet replacement for 5 weeks every 4 months. And of course, the two were matched perfectly in terms of the amount of product. At the end, and these are the figures for the measurements made in the dietitian's office, the independently verified figures in the clinical research unit gave these figures here, which represented a change of 0.7 or 1.78 kilograms. There's no significant difference between those. So it represented a maintenance of about 10%. So these are in older people with knee osteoarthritis, in whom those of you who have been involved in the management of these individuals, particularly if they have diabetes, have great difficulty in achieving weight loss and then also in maintaining it. This can actually be done by this method. But of course, again, they were fairly intensively managed throughout. So to summarize very briefly, total diet replacement offers an additional option to deliver amounts of weight loss between the values that are usually gained by conventional diet, perhaps up to 5 kilograms or a little higher in some cases, and then the amounts of weight loss that are achieved with bariatric surgery, where we see much greater weight losses. The rates of weight loss are fast, and it's important to note that this can be quite motivating. Individuals who've lost 1 or 2 kilograms after 10 or 2 weeks are really then quite strongly motivated to continue. They can be delivered in specialist primary care and community settings. There's experimental evidence in all of those settings. Compliance tends to be high. Safety profile is good. All of the adverse events are fully described in the publications. And for the examples that I've referred to, weight loss in knee osteoarthritis greatly reduces pain, and that pain reduction is actually maintained, provided weight reduction is also maintained. And in obstructive sleep apnea, there's a big improvement on the sleep state and also an improvement in quality of life. Nerys and Mike will a little later on discuss the evidence in relation to reduction of medication costs, and also calculations have now been done on the cost effectiveness of this type of program. Thank you very much. So I will now move on and introduce Nerys. Nerys is a senior research fellow at the Department of Primary Care Sciences in Oxford, and will now talk to us about the Droplet trial. She's also an advisor to NHS England on the program that is currently underway in relation to the rollout of TDR for diabetes remission, and is involved in a number of big trials on dietary management of obesity in that department. So Nerys, thank you very much indeed for being prepared to tell us all about Droplet and related observations. Thank you.
No, thank you for inviting me, Tony. Can you hear me okay?
Yes, we can.
Great. So I think Tony's done the introduction, and I will introduce myself again. So I'm going to talk about the droplet trial today, and the droplet trial stands for the doctor referral of overweight people to a low energy total diet replacement trial. I didn't do a slide on my declarations, but I will say that the initial droplet trial with 1 year follow-up was funded by the Cambridge Weight Plan. We've also received some small grants from the NIHR to do the 3-year follow-up and qualitative interviews and cost effectiveness analyses. So what is a total diet replacement program? So Tony's explained really nicely what these products are, but I think it's really important that you understand when I refer to a total diet replacement program, I refer to a program with 2 components. So the first is a period of total diet replacement using the products Tony's talked about, these low energy formula diet products, and they're used to replace all foods in the diet. And there's usually typically things like soups, shakes and bars, and they provide between 800 and 1200 calories a day, and they're formulated to provide all essential nutrients, vitamins and minerals. The second component, and I think this is really important, is that this period of total diet replacement and food reintroduction is accompanied with regular behavioural support. And what do I mean by that? I mean contact with a person. It could be in person, virtually, in groups or in a one-to-one format, and a counsellor, dietitian, GP, medic, nurse, whoever that might be, gives support to the participant in replacing all their foods and the food reintroduction period, and deals with things like goal setting, motivation, and any problems they may have. So what was the evidence that we had before the droplet trial? Well, we know that programs that I will refer to as behavioural weight management programs, so these are programs which specifically only include the behavioural support component. And in this systematic review by Helen Peretti, when she was at Birmingham, she compared these behavioural weight management programs with very low energy diets, which tends to be total diet replacement programs. And there were several randomised controlled trials included in this systematic review. And what she showed is that on average, the total diet replacement or very low energy diet programs achieved an additional 4 kilos weight loss after 1 year compared with the behavioural weight management program. So it is important to note here that as weight loss achieved in the behavioural weight management program, the average absolute weight loss is approximately 10 kilos after 1 year. And what we were really interested in is whether this kind of program could be implemented into a primary care setting. So that we know that weight loss confers an additional health benefit, and the more weight loss that you can use, the greater the benefit. And although the behavioural weight management interventions are successful, we need more options for managing obesity, specifically in primary care. And this led us to the droplet trial, which was an individually randomised controlled trial. We conducted this trial in 10 GP practices in the Oxfordshire region, and the practice searched their electronic record for patients who had a recorded BMI of above 30, and we enrolled 278 patients. And the only real exclusion we had was patients who were actively on insulin or that had any contraindications to the TDR products. And patients were randomised in a 1-to-1 allocation to either receive the intervention or the comparator. The intervention included referral to a total diet replacement product, which was delivered in the community by the Cambridge Weight Plan. And that involved a period of 8 weeks total diet replacement, followed by 4 weeks gradual reintroduction of regular foods, plus a 12-week weight loss maintenance plan with the aim of maintaining weight following the weight loss phase. The comparator was a nurse-led behavioural weight management programme, which we called Usual Care, and practice nurses delivered a weight loss intervention following the British Heart Foundation booklet guidelines. The primary outcome was weight loss at 1 year, but we also had a raft of secondary outcomes, including a lot of cardiovascular disease risk factors, including blood pressure, lipids, but also some diabetes indicators such as HbA1c, and also quality of life. So before the participants who were randomised to the community-led total diet replacements, their clinician adjusted any medications they were taking before they commenced the programme. And this guideline is available online on the Department of Primary Care website if you're really interested. It's one of the things I'm mostly requested for. But these adjustments were generally, they were taken off all their diabetes medication apart from their metformin and taken off all their antihypertensives. Clinicians were a little resistant to this at the beginning. But once they got into the hang of it, they realised that they weren't experiencing as many adverse effects or seeing the patients as much as they thought, and then were happy to do these adjustments. So following the one-year outcomes of the droplet trial and the publication of the paper, the most frequent question was, well, this is really interesting in the short term, but what happens in the longer term? And we were successful in getting a grant from the NIHR Clark at the time to follow up the droplet participants of 3 years. So all the participants that took part in the main droplet trial were invited back for a 3-year follow-up, and the follow-up rate was 64%, and that's compared with approximately a 73% follow-up rate at 1 year. So what were the results? Well, as you can see, participants in both groups lost weight, and maximum weight loss was seen at approximately 6 months. And this coincides with the completion of the total diet replacement, but also the usual care programme. Our primary outcome, which is weight change from baseline at 1 year, was approximately 3 kilos in the usual care group and about 11 kilos in the total diet replacement group. And when we did our statistical analysis, this adjusted difference resulted in an additional 7 kilos weight loss in the total diet replacement group compared with the usual care. We did see weight regain in both groups, with a little more weight regain in the total diet replacement group compared with the usual care group at 3 years. An average weight loss from when they enrolled in the trial, not from the 1 year follow-up, was approximately 3 kilos in the usual care group and about 7 kilos in the total diet replacement group. And this resulted in an adjusted difference of about 3 kilos additional weight loss in the total diet replacement group compared with the control after 3 years. So when we look at the proportion of participants achieving that cut point of 5 or 10% weight loss, as Tony said, which is generally accepted as the thresholds that may achieve health benefits. What we can see here at 1 year, the proportion of participants achieving 5 or more % weight loss was almost 5 times greater in the total diet replacement group compared with the control. And again, almost 5 times more likely to achieve a greater or equal than 10% weight loss in the total diet replacement group compared with the control. And almost 50% of participants in the TDR group had achieved this threshold. If we go and look at these at 3 years, we can see that participants in the TDR group were about 1.5 times more likely to achieve 5 or more % weight loss at 3 years, and almost 2 times more likely, twice as likely to achieve 10% or greater weight loss at 3 years, although these values didn't reach a level of significance. So as Tony explained, we recorded any adverse events that happened during the first 3 months of the programme, and at 6 months for any gallstone-related events to allow for any diagnostic delay. So we reported that any adverse events occurred in 52% of participants in the total diet replacement group and 30% of participants in the usual care group. And this was a treatment excess of 1 in 5 cases. The most common adverse events we had with an excess in the TDR group compared with the usual care group were constipation, fatigue, headache, and dizziness. And when we looked at those adverse events that we classified as moderate or greater severity, these occurred in approximately 11% of the TDR participants and 12% of the usual care participants. So although overall adverse events are higher in the TDR group compared with usual care, when we look at the more severe adverse events that affect activities related to daily life, they're roughly equivalent between the groups. We only had one serious adverse event occur in the trial, which occurred in a participant who was in the TDR group, but it occurred after they'd been randomised, but before they initiated their TDR treatment. So when we look at the one-year outcomes in relation to some of the cardiovascular disease risk factors, we can see there was a reduction in systolic and diastolic blood pressure in the total diet, greater reduction in the total diet replacement compared with the control, although only the diastolic blood pressure reached a level of significance. We had a greater reduction in HbA1c in the total diet replacement group compared with the control. There was no effect on LDL cholesterol, but we did see that the Q-risk score, which is a score that uses a number of variables to calculate the percentage risk to participants of having a cardiovascular event in the subsequent 10 years, was reduced in the total diet replacement group compared with a control, and this did reach the significance threshold. I think this is really important because the main driver for Q-risk is age. So as participants age, you would expect their Q-risk to increase. And what happens in the total diet replacement group is that's offset by the weight loss that they've achieved. The EQ5D, which is a measure of quality of life, was not one of our pre-specified outcomes, so we didn't conduct any statistical analyses, but it appeared that the total diet replacement group had an increase in this score greater than the usual care group. And at 3 years, we can see similar outcomes. So at 3 years, both systolic and diastolic blood pressure were reduced in the total diet replacement group compared with the control. There was no effect of HbA1c, with a rebounding of the HbA1c seen in the total diet replacement group, although there was no significant difference between the groups. Again, no difference in LDL cholesterol, which seems to be associated with cardiovascular disease risk. And again, the Q-risk score was reduced in the total diet replacement group compared with the control, although this didn't reach the level of significance. When we looked at the quality of life score, what we saw is in the usual care group, this score had increased compared with baseline in the usual care group. And this was greater than the increase seen in the total diet replacement group. So there was a greater effect in the usual care, and this did reach the level of significance. So when we published the paper, one of the most questions that we got asked is, so this is really interesting and can show the clinical effectiveness of the total diet replacement program as a routine treatment for obesity in primary care. But these products and these programs do come at a cost, and they do have a premium cost. And what is the long-term effectiveness and cost effectiveness of these programs? And in order to estimate this, we use a modelling procedure, an economic modelling procedure, to see whether the weight loss is achieved during this 1 year program with a 3 year follow-up. So the benefits in disease reduction incur a benefit in costs in the longer term. And we use a model that is called the prime time obesity model. And what this model does is it simulates the impact of changes on the distribution of BMI, on mortality, but also on incidence of diseases that are associated with obesity, things like type 2 diabetes, coronary heart disease, stroke, cancer of the breast, colon, liver, kidney, and pancreas. And what this model does, it uses data from population studies, epidemiological studies, and cohort studies, as well as national data on the costs of treating these diseases to calculate what the adjusted cost would be if we reduce the population distribution of BMI in a similar way that was seen in the clinical trials. And for this modelling, we had to attribute a cost to the programmes. And what we did for the total diet replacement programme is use the retail cost, and that is of the products, but as well as the behavioural support. And that roughly came to about £800 for the protocol that we delivered in the droplet trial. And that compared with a rough estimate of £34 for the nurse-led support programme. So one of the really important things when we do this modelling is, although we knew what weight loss had been after the 1-year programme, we didn't know what longer term weight loss would be or weight maintenance would be following the weight loss. And we needed to make some assumptions or predictions on what would happen to body weight in the long term. And we used evidence from large previous studies to see what happened after periods of weight loss in both the control group and the total diet replacement group. So in the control group, what we did is we assumed that they'd received the 3 kilos weight loss that was seen in the clinical effectiveness results. And based on previous papers, we assumed that they would regain the weight that they'd lost. And by 5 years, they would have regained all the weight that they'd lost as part of the trial and continue at the same weight they were at baseline for the rest of their lives. In the total diet replacement group, we used 2 different assumptions. So we assumed that the same thing would happen, that participants would regain all the weight they'd lost during the droplet trial, and by 5 years, on average, they'd weigh the same amount as they did when they entered the trial, and they would continue for the rest of their lives at this weight. The other assumption we used is based on some large studies in the US, which suggests that not all the weight is regained. And by 5 years, participants are about 1 kilo lighter than when they originally enrolled on the study, and then they continue to be 1 kilo lighter for the rest of their lives. So the results of the cost effectiveness analysis, we show that total diet replacement program does the weight loss associated with the total diet replacement program has an increase on the years of life. It also has an impact on the number of cases of coronary heart disease, stroke, type 2 diabetes, and cancer that would be expected at population level if the BMI distribution was reduced to the magnitude seen in the droplet trial. And when we base this calculation, we calculate what we call an additional cost per quality adjusted life year. And the estimate of this was approximately £12,955 per quality adjusted life year. And this value for quality adjusted life year was assumed that all the weight was regained by 5 years. The cost per quality adjusted life year was reduced to about £3,000 if we use the alternative assumption for weight regain. That is that participants regained but were 1 kilo lighter at 5 years and continued across this. And just to mention that the threshold for cost effectiveness considered to be cost effective by the NHS in England is roughly £20,000 per quality adjusted life year. So using both assumptions for weight regain, the total diet replacement programme would be cost effective below that threshold. We also did some subgroup analyses on cost effectiveness, comparing different types of participant. So using both assumptions of weight regain, there was no difference between males and females in the cost effectiveness of the programme. When we compared by age groups, the cost effectiveness seemed to increase in a linear fashion. So in the older age groups, the programmes became more cost effective. And this is probably because they're higher risk, or they begin they enter the analysis at a higher risk of developing conditions like coronary heart disease and type 2 diabetes. And when we compare the baseline body mass index and we split this into tertiles, again, we see that the programmes become more cost effective using either assumption for body weight regain as the BMI increases. Although it is important to note that even at a BMI of 30, the threshold for obesity, these programmes are considered cost effective in BMI 30 to 35, 35 to 40 and above 40. We can also do some reverse modelling, which lets us calculate what the threshold would be for the costs of these programmes in order to determined cost effective at the £20,000 per year threshold. And what we can see here is the base cost of the TDR programme that we delivered in the droplet trial was approximately £800, £796. And using the assumption for participants returning to their baseline weight at 5 years, we can see that a programme cost of £362 would yield to the net monetary benefit, and a programme cost for participants to maintain 1 kilo weight loss at 5 years, the net monetary benefit of £20,000 per QALY, the NHS threshold, the programme could cost up to £2,722. And since we've done the longer term follow-up at 3 years and the direct trial have done their follow-up at 2 years and they're pending the results at 5 years, we can actually map our weight regain trajectories to see whether the assumptions that we made about cost effectiveness were appropriate. And what we can see is that in the direct trial, although they only have 2 years follow-up, so we don't really know what the trajectory is, but they absolutely would meet the criteria that we use, that weight regain would be regained within 5 years. And then the droplet trial, it appears that it would take a little bit longer, but again, they both meet the assumptions for the cost effectiveness, the assumptions about regain that we used in the cost effectiveness analysis. So in summary, referral to a commercial diet replacement programme was feasible, acceptable, safe, clinically and cost-effective treatment for obesity in routine primary care. The weight losses averaged approximately 10 kilos at 1 year, and 45% of patients lost 10% or more of their baseline weight. And at 3 years, weight losses averaged approximately 7 kilos, and 23% of participants lost approximately 10% or more of their baseline weight. There were significant improvements in biomarkers of cardiovascular disease risk and diabetes at 1 year, and other trials that I'm sure Mike will talk about suggest that patients taken off all their diabetes medication, 45% of patients with type 2 diabetes can cease their medication. However, at 3 years, only blood pressure remains significantly different than at baseline, and we need to look into this further, but it is probably due to the weight regain profiles that we see. The cost per quality adjusted life year is less than £20,000 threshold, usually considered cost effective by the NHS, and the programme becomes more cost effective in higher risk groups. And this is important to note when kind of making commissioning decisions. I usually finish with this point, and I've moved it to a different slide, that TDR is currently not recommended by NICE except for acute weight loss, and it's generally not available on the NHS, but is widely available for patients who are willing to self-fund, of course with support from your GP for medication adjustments. But currently the NHS are piloting a low-calorie diet programme in up to 5,000 people living with obesity and type 2 diabetes in England, and we really anticipate the results of that pilot, which uses different models of delivery, so compares different models and how rollout could be achieved.
Thank you very much. Thank you. Can I just say that on the abstracts and notes that were circulated, I did actually add in the web link to your pages on the website in your department about medical management, drug management and so on, so that those who are interested would know what the link is. So I've actually provided that for individuals. Thank you. No questions specific to that talk have actually appeared yet, although I've got one from Hilda Marinus in Brussels, which we'll take right at the end, if we may, Hilda, please. So we move on now to the presentation by Jennie Brand Miller. And those of you who thought about this would probably wonder, well, it's about 2 o'clock in the morning for Jennie. So in actual fact, we have pre-recorded this presentation. So we will now listen to Jennie's presentation. She is Professor in the Human Nutrition Department at the University of Sydney in Australia, and as most of you know, is one of the leading world experts on glycemic index and glycemic load, and runs organizations which provide the data about the dietary variables. She was a principal investigator in the preview trial, running the group that were investigated in Sydney, and she's now going to summarise the preview trial for us. Thank you.
Welcome, everybody. I'm very pleased today to be able to present some of the new findings in the diabetes prevention study called Preview. This study was funded by the European Union to the tune of about $13 million, and it was completed and published in the year 2020. The coordinator of Preview was Professor Anne Rayburn in the University of Copenhagen. So we're going to go to the next page. It's not going. All right, I have a duality of interest to declare, which you can see there on screen, all things to do with the glycemic index of foods. So Preview is a landmark study, one, because it was multinational, and two, because it was the first to use meal replacements for the initial weight loss stage. It was the first to compare two diets and two exercise intensities. And it also went for much longer in terms of weight loss maintenance, 3 years. So the 8 sites in Preview were Copenhagen, Helsinki, Nottingham in the UK, Sofia in Bulgaria, Maastricht University, University of Pamplona, and in the other hemisphere, Sydney and Auckland. So 8 sites altogether, and these were the aims of the Preview project, to find a more effective way to reduce diabetes. So we know from previous diabetes prevention studies that weight loss is extremely important. They aimed for 5% in the DPP, and they aimed, in the Finnish study, and they aimed for 7% weight loss in the diabetes prevention study. Here we aimed for much more. So the aims were also to compare two diets, one being higher in protein, lower carbohydrate, and lower in GI. The other diet being the official, healthy, conventional diet. We also wanted to compare 2 levels of physical activity, moderate versus intense, and I'll tell you some more about those diets and exercises as we go through the talk. And we wanted to compare weight loss maintenance in a long phase at the end of the first phase of weight loss. We also took this opportunity to ask lots of questions about sleep and stress, and to look at sociological and behavioral factors that might influence weight loss and weight loss maintenance. So in Preview, the inclusion criteria included women and men between a BMI of, an age of 25 and 70 years. So they were younger than in many other diabetes prevention studies. We included people with overweight and obesity. They were screened for pre-diabetes by the ADA criteria, which includes a fasting glucose. You can see the numbers there, or a 120-minute post-glucose load value between 7.8 and 11. They needed to be willing to undertake 7 very full clinical investigation days over the period of the 3-year weight maintenance loss period, including baseline, 8 weeks, all the way through to 3 years. They had to be willing to attend 17 group sessions, and they had to be willing to collect data at regular intervals. And this data include 4-day dietary records, 7-day accelerometry, and 24-hour urine samples. So you can see the burden on the participants was very high. We used a group lifestyle behavioral modification with fading frequency of contact. So it included a phase 1 of weight loss, which was 8 weeks of meal replacements. If they lost at least 8% of their starting body weight, they were eligible to start the weight loss maintenance stage, which went for 34 months and included diet and exercise and behavioural changes. So in this, you can see that there was frequent contact, 4 visits, 4 group visits during the meal replacement phase. It continued during the weight loss maintenance, fortnightly visits, then monthly visits, and then less frequent visits as the time went on through to the 36 months end point. So the phase 1, 8 weeks, was unique for diabetes prevention trials because we used total meal replacements. And these products allow a very fast weight loss because they allow a very low calorie intake of, in this case, 810 calories per day. They were allowed some salad vegetables, which allowed them to eat the main meal of the day with their rest of the family. It allowed for fast weight loss because of the deficit being so large between maintenance, what they needed for weight maintenance and what they needed to lose weight. During this phase, they didn't have to do any exercise whatsoever, something they were very pleased about. And this phase set the scene for the weight loss maintenance phase, which was the target of this study, was to look at weight loss maintenance as a component of diabetes prevention. So phase 2, some more about that. They were randomized to one of 2 diets, and this is the first time that 2 diets have been compared, 2 diets of different composition. The special diet, the one that we were particularly interested in, was the higher protein diet with lower glycemic index carbohydrates. And I'll show you some more about that in a minute. It was 25% of energy as protein was the target, 45% as carbohydrate. Whereas the moderate protein, moderate GI diet, the one that was the conventional diet for weight loss maintenance, was only 15% of energy as protein and 55% of energy as carbohydrate. And of course, the GI was higher. So they were also randomized within each diet to 2 exercise regimes. One was high intensity, and that effectively meant getting their heart rate over 75%, but they needed to only do about 15 minutes a day on 5 days a week for their exercise. The same in terms of VO2 max, the moderate intensity went for at least 60% of maximum heart rate, but for a longer period of time, about 30 minutes on 5 days a week. So I just want to show you what that meant effectively in terms of the intervention groups. So there were 4 intervention groups. And if you look carefully, you can see, I'm hoping you can see my mouse there. The first 2 diets were moderate protein. And you can see there's a smaller amount of the protein in there and a larger amount of carbohydrate. The second 2 diets were higher in protein, and you can see that there's a bigger piece of salmon there. And you can see within each of the high protein groups, you have moderate and high intensity. But what I'm going to show you here is that the names for those 4 interventions were moderate protein and moderate intensity, high protein and moderate intensity, HPMI, then moderate protein with high intensity exercise, and high protein with high intensity exercise. So I just want you to note those abbreviations for the 4 interventions because I'm using them in the next slides. So at the end of the weight loss phase, we have an amazing group of people who feel like new people. They are, they've actually achieved weights that they've never been since they were aged in their 20s. So to get this group of people, we were had to screened for at least 15,000 adults. We screened them with the Finnish risk score. Then we screened them more particularly for their glucose tolerance. So over 5,000 tests, glucose tolerance tests were done. So out of that group, about half, 2,326, were eligible. As is typical, 2/3 were women. The average age was 52, and the average body weight was 100 kilograms. And in terms of BMI, that's 35. So on average, they have obesity. Now, we had a very high rate of completion of this phase. We expected 75%, but it was 79% that achieved at least 8% of weight loss. And in fact, they overachieved. They lost, on average, 11% of their initial body weight. Some of them lost as much as 20% of their body weight within those 8 weeks. And now I want to show you the findings at 3 years. We've got, first of all, the completion rates. We had a high completion rate of 12 months, nearly 75%, or 3 in 4 participants were still part of the study at 12 months. But unfortunately, by 36 months, a study with this degree of burden had just over half of the subjects that were eligible to start the 8-week weight loss phase. The participants who developed diabetes during this 3 years, there were only 62. We actually expected many more. The cumulative incidence of type 2 diabetes was only 3.1%. We expected 13.5% on average would develop diabetes, 10% in the high protein, low GI group, and over 16% in the moderate protein. So we're much lower than we expected. And of course, with so few subjects with diabetes, there were no significant difference between the diets or between the 4 intervention groups, including the exercise groups. And this applied to most outcomes. There was one that was significantly different. I'll tell you about that in a moment. Of course, we don't know the number of cases of type 2 diabetes in the dropouts, but something that we do know is that there was a similar, very low rate of diabetes in all centres, irrespective of the dropout rate. So in many of the centres, we had over 75% completion rate compared to some of the other centres. So we don't think that we missed the cases of diabetes, too many cases of diabetes. So this is your Kaplan-Meier graphic. You can see here, it's not different between the 2 groups of 2 dietary groups, high protein versus moderate protein, for the whole 3-year period. But we have some interesting findings with respect to weight loss maintenance. Although there was no significant difference among the 4 groups, and you can see the 4 intervention groups there, we did have extremely good weight loss maintenance. 1 in 2% maintained a clinically significant 5% weight loss. And in fact, 1 in 4 maintained a 10% weight loss. And this is higher than in other diabetes prevention study. But of course, there was a group of subjects, about 1 in 5, who actually did worse. They regained the weight they'd lost and some more. And this group is particularly interesting to us, and they're the subject of further studies. This is the difference that was significantly different, the one secondary outcome that was different. We don't think it's by chance. It was highly significant. And what it showed was that the 2 high protein groups, the curve you can see there in orange and red, those 2 groups had fewer participants who achieved normal glucose levels during the weight loss maintenance period. And I think this sounds a little note of caution with respect to high protein diets, that perhaps we need to study them a bit more in terms of diabetes prevention. Fasting glucose rebounded quickly. You can see there that the fasting glucose was the same in all 4 groups at the 36-month time point, and so was HbA1c, and so were all the blood lipids. There were no differences between the diets, exercise groups, or any of the 4 intervention groups. I want to say something about the composition of the diets. At 6 months, we have our best compliance. This is the phase where they're attending group visits most frequently. What we found was that the high protein group did not achieve the 25% that we aimed for. The average was 22%. In the moderate protein group, they ingested more protein than we wanted to, so we were aiming for 15% and we got 19%. The same, we have some reciprocal differences in carbohydrate. Remember, we're aiming for 45% here and we're aiming for 55% carbohydrate in the moderate group. The GI we achieved was comparable to our targets, 51 and 56, but of course we would have liked to see a bigger difference, and the same with glycemic load. And then the differences between the 2 groups are smaller at 12, 24 and 36 months, but still highly significant. So in some ways what we did was overachieve the dietary targets that we were aiming at. So this is showing you the compliance with protein intake. So we've got the 4 intervention groups, the 2, the orange and the red are the high protein groups, the green and the blue are the moderate protein groups. So this is in terms of the urinary output of nitrogen. We can tell whether they achieved what levels of protein they achieved in their diet. And you can see there that all 4 groups went up compared to baseline in terms of protein. So this is a bit of a shame. And by the end of the 36 months, all of them have achieved a higher protein intake compared to baseline. Now I want to show you the longitudinal associations with GI, glycemic index and glycemic load. This was a secondary pooled observational analysis where we pooled all subjects into one group, and we looked at the 3-year weight loss maintenance, and we looked at 4-day dietary records. So there were 1,280 participants who completed 4 days of dietary records at regular intervals, 6 months, 12, 18, 24, and 36 months. And what we've done is used linear mixed models and repeated measurements to compare the groups in terms of glycemic index and glycemic load that were actually achieved according to the dietary records. So we divided them into tertiles. And this is what you see here. So just look on the left side to begin with. So the group that achieved the lowest glycemic index overall are shown in orange. The group that had the highest glycemic index, the 33% of subjects with the highest, are shown in green. And what you can see on the left is body weight. You can see that as time went on, the highest glycemic index group regained the most weight. The lowest glycemic index tertile achieved the lowest body weight regain. And the same with HbA1c, and the differences are very pronounced. The lowest GI group, tertile, have basically achieved very low levels of HbA1c, something we want to see. So this tells us that these diets, even when they've been adjusted for energy and adjusted for body weight, are still showing differences that are dictated in HbA1c, dictated by the actual GI, the diets. This next graphic shows you glycemic load and body weight changes. And again, the highest tertile have the highest regain of body weight and the highest rebound in HbA1c. So we think that any adverse effects of this diet are because of protein intake rather than in GI. And this last, I'm coming to the end of my presentation. I wanted to show you one recent meta-analysis of observational cohort studies that examine relationships between glycemic index, glycemic load, and the risk of type 2 diabetes in people in the normal population. And what you can see there in those graphics, that for both glycemic index and glycemic load, there is a predictable increase in the risk of diabetes, developing diabetes, as GI and GL increase. And this degree of risk is comparable to exercise, the ability of exercise to reduce the risk of diabetes. So they are substantial food markers, and they apply to people of both European and East Asian origin. And so now I want to sum up what we concluded from the previous study. First, we achieved a remarkable reduction in type 2 diabetes incidence. If we compare it to what we expected, it's a 75% reduction in risk. What are the reasons for such a low incidence? First, these are we think are the possibilities. First, we think it was the large initial weight loss, twice that was achieved in the Finnish diabetes prevention study. We think it was the fact that they were able, many of them, 1 in 2, were being able to sustain that weight loss of at least 5% for the duration of the 3 years. We think some of it is because they increased their protein intake. Both groups increased their protein intake and reduced their carbohydrate intake. So both of those factors might be operating. And lastly, we think it is the lower glycemic index and lower glycemic load, which may facilitate larger reductions in fat mass and HbA1c. So finally, I want to acknowledge the people that, the groups that allowed preview to take place, mostly the European Union, but also the Australian government, the New Zealand government, Cambridge, who provided all the meal replacements for the first weight loss phase, the Glycemic Index Foundation, and the Danish Meat and Research Institute. And finally, in the last slide, you can see all the numbers there for future reference. So thank you very much. I would be happy to answer questions if it was possible, but this presentation will take place in the immediate, in the middle of the night, Australian time. Thank you.
Okay, so thank you very much to Jennie. I'll send her a note expressing our appreciation, and obviously I did speak to her when we made the recording. So we'll move on immediately to the presentation by Mike Lean. Mike will be known to many of you already. He's a principal investigator of the DIRECT trial, and we're eagerly anticipating the 5-year results in coming months. But in the meantime, he's going to talk about the first 2 years of this trial. Mike is a professor of human nutrition at the University of Glasgow, and is also climbs mountains, and I think that's actually very useful when you're trying to useful experience in overcoming obstacles, which we all have to do in the course of translating good research findings into practice. Mike, thank you.
Thanks very much indeed, Tony. Climbing mountains is a very good training for many things. I often think that Andy Murray, who climbed some mountains, is himself used to actually facing danger. Now, I'm going to attempt to share the screen and take you through a presentation which I hope will be of some interest. And with a bit of luck, it should now be there. And let just pause to say that this is a painting by Frederick Banting, and I keep telling people this is Frederick Banting was the man who won the Nobel Prize precisely 100 years ago for the discovery of insulin. He was a very third-rate doctor, a dreadful scientist, but very, very lucky. But he was a very, very good oil painter. And that's his little story. So my disclosures are shown here, and none of what I'm going to say had any commercial support or government support. I'm going to talk mainly about the direct trial, which was charitably funded from Diabetes UK. And I'll mention here also that the slides, or many of the slides for the direct trial, are up on the website, and a lot of other information, directclinicaltrial.org.uk. Now, I'm going to speak mainly about type 2 diabetes, and that is because type 2 diabetes, when I was a student, was considered sort of little brother of type 1 diabetes, something it happened in older people who didn't matter very much. And as a disease, it mostly didn't cause too much trouble. You took a pill and came back in a year's time. But we did know, we believed, that it was a permanent condition, it was incurable, and that it was progressive. So if you were unlucky and developed it young, then it could cause trouble. Now, things have changed absolutely radically since I was a student. And the main thing is that the onset of type 2 diabetes has moved down from an average age of nearly 70 down to about 50. Low 50s, 51, I think, in the UK. And that means that most people who develop this disease do get disabling, painful, and completely incurable complications. And here's a list of them. These are dreadful complications. This is a very serious disease. And I'll show you one more slide to sort of cement this idea. I've listed here 3 diseases which most people would consider to be important diseases. Most people who develop breast cancer are worried, frightened, and treat this seriously. They would, if offered treatment for remission, which might be chemotherapy with very nasty side effects, they would take it every day as instructed, because this is a serious disease. It has an 80% 10-year survival. 80% of people will live 10 years with breast cancer on average. Non-Hodgkin's lymphoma is a much worse cancer, taken very seriously, and it has a 60% 10-year survival. So 60% of patients will live 10 years. Type 2 diabetes, which has a similar age distribution to these cancers, only 50% 10-year survival. This is a very serious disease, and we need to take it much more seriously. And what we've learned in recent years is that type 2 diabetes is not a separate disease, the little brother of type 1. It is, in fact, all part and parcel of what we now call the disease process of obesity. So disease process as defined by the WHO, and I think perhaps the Scottish Sign Guideline of 2010 got in there first to say that obesity is not a BMI of 30 or a BMI of or waist or something like this, but it is a process, a metabolic process with genetic, epigenetic, and environmental factors in its etiology, and is a progressive condition which starts at one point and moves to others, and obviously reveals itself in different ways to different people. One way it reveals itself is by developing type 2 diabetes and metabolic syndrome. So that's the story. And we know that this disease is terribly closely related to weight gain. This is a very famous study from Graham Colitz in North America, which shows that at the left-hand side here, with a body mass index of 22, this is a very comfortable place to be. And you'll notice that somebody, that is me actually, on the top of a mountain in the Alps with a body mass index of 22. And at that level, I can expect to climb mountains for many, many years. However, body mass index of even 25 has a relative risk of about 8 to 10. That means people have 8 to 10 more likelihood of developing diabetes than perhaps I would. I'm lucky, but that's how it is. With a body mass index of 30, the relative risk is 30 to 40 times, and this risk goes up to astronomical levels. This association cannot be by chance, it is causal. And we know, obviously, also that the epidemic of type 2 diabetes, developing over the last 30 or 40 years, has followed the epidemic of obesity. We now talk of them as a syndemic. It's the same condition. It's 2 epidemics which are totally linked and running together. It's the same disease process, and it's called obesity. Now, we also know, there are many studies confirming this, that quite modest weight loss can prevent the onset of diabetes. And you've heard from our previous speakers this evening that the onset of diabetes can be delayed or perhaps even prevented completely by quite modest weight loss. By modest, I mean what can be achieved with a dietitian. In these studies, this is the Diabetes Prevention Project, about a 7 kilogram weight loss, maintained quite well, half of that weight loss maintained for 4 years. And that was enough to knock out, to prevent more than half the new diabetes. And you heard from Jennie Brand Miller that this can be achieved with different diet types. It doesn't really matter what the diet type is. They all have the same benefit. If there is weight loss, it will prevent the onset of type 2 diabetes. Our question was, can we actually take one step further and tackle the disease itself once it has been diagnosed, once it's developed? And some of the strength behind this came from a very old study we did in Aberdeen in Scotland, published in 1990. And here's the slide from that paper. And what this shows is on the x-axis, the years of life lost with type 2 diabetes. These are people who are overweight, BMI over 25, with type 2 diabetes, according to their weight loss in the first 12 months after diagnosis. So this is the weight loss achieved with the help of the dietitians in the clinic. In those days, every patient was seen in the diabetic clinic, was seen by doctors and by dietitians who reinforced the message that weight loss is vitally important. Some lost weight, some didn't. Those who did not lose weight, 0 here, died approximately 6 or 7 years younger than people who never had diabetes in the same population. And that figure, approximately 6 or 7 years younger, is still the case now, with much more recent data from big European studies. So despite our modern treatments for diabetes, people are still dying younger through complications. And this is tragic because so many of them develop disease at a much younger age. Now, as they lost weight in this old study, you can see their survivals increased. And we published data up to 14 kilograms weight loss, at which point the survival of our people with overweight type 2 diabetes, their survival was exactly the same as people who never had diabetes in the same population, the general population in the north of Scotland. And that suggested to us that 14, and I sort of moved up to 15 kilograms, because it's a nice round figure, it's approximately 2 stones in our patois in Scotland. 2 stones weight, 15 kilograms weight loss would be associated with return to a completely normal life expectancy. That suggests that disease process has been knocked out. This was using retrospective data from people who were followed for many, many years. It was not a randomized controlled trial. It was supported by some evidence from bariatric surgeons who've been saying for years that with their sort of weight losses, that type 2 diabetes can go into remission. And this is a collection of studies in different centers using different operations. The blue columns show the data at 2 years. And if you run your eye across this, you can see that 72, 75, 68, 85% of patients were in remission at 2 years using different operations with weight losses of 23%, 45%, 35%, 33%. The green columns show that at 10 years or 6 years, the remission rates have fallen. So some of the people who were in remission at 2 years are no longer in remission at 5, 6, 10 years because they have regained weight. And even after bariatric surgery, there is weight regain later. But these data suggest that this disease really should be reversible. The question, though, is could we achieve this with a lesser weight loss than these heroic bariatric surgical approaches? And the answer came from really a single study from John Dixon and his colleagues in Melbourne, in Australia, published many years ago now, 2008. And this is a very small study, but it was a randomized controlled trial between bariatric surgery, gastric band surgery, and continuing in the diabetes clinic. And what they looked at in this diabetes at 2 years, and this slide shows in the open symbols, those individuals who are no longer diabetic at 2 years. And you can see actually most of these who had surgery were no longer diabetic. The figure is 73% compared with just 2, and that makes 13% of the patients who continued in the diabetes. And I have put a line in this slide at 15 kilograms, the same figure that we derived in our Scottish study. People who lost 15 kilograms, 83% were no longer diabetic. A fantastic figure. Now, if we could translate that into large numbers of ordinary people and perhaps achieve it without surgery, this would be very exciting. John Dixon and his colleagues actually put their line at 10%. And they got exactly the same figure because there's such a small study, there are no patients in that interval. But I felt that it was safest to go for the 15 kilograms weight loss rather than 10% based on our Aberdeen experience. And that was the sort of driver behind establishing the DIRECT trial, Diabetes Clinical Remission Trial, which showed, well, I'll tell you the results, but this was a study which aimed to look at whether it was possible to deliver a weight loss program for people with diabetes, type 2 diabetes, in primary care. And it's quite an ambitious study with the aim of achieving remissions. And it was the first study ever to be designed with a non-surgical approach aiming for remissions of type 2 diabetes. And I might tell you that it was a very long process to be able to get funding for this, because many people did not believe that we could achieve remotely the same sort of weight losses or sustain them. And they felt that the patients would not be willing to do this kind of intervention. These people critics were fortunately wrong. The study was conducted in Scotland, across Scotland, in many villages up and down the country, and in the northeast of England, together with my colleague Roy Taylor, who took a subset through some mechanistic studies in Newcastle. And I'll show you those as well briefly. Study design was very simple. We randomized practices and the people in them to either continue as control practice where they received best practice guidelines for all the current treatments for diabetes, and methods of follow-up. That is the SIGN guidelines in Scotland and the slightly newer and more bulky NICE guidelines in England. And the intervention group received exactly the same quality of care with the same guidelines, plus an intervention program, which I shall show to you. And we aim to recruit very, very ordinary people with type 2 diabetes. And these are people, and I can show you their criteria here. We aim to get people from 20 to 65 years of age. We had an upper cutoff only because we intended to follow them up for a number of years afterwards, and we quite like them to remain alive. The average age was 54 years, and that was with an average duration of diabetes of 3 years. So their average age of onset, 51, was exactly the same as that across the country. We limited the restriction, recruitment to people with less than 6 years duration of diabetes. And the reason for that is because we know that with much longer durations, over 10 years, then remission becomes less likely. And these people, because of short duration, were not yet on insulin. So we didn't include people on insulin in this study. They came from more deprived areas of the country, and we selected them on purpose because with multiple deprivations, diabetes is more common, and it's also more difficult to treat. So we picked a pretty tough group here. Their average age was 54, I mentioned. Their body mass index was 35, again, fairly average for a group of people with recent onset type 2 diabetes. The intervention was delivered entirely by practice nurse or dietitian, if there was a dietitian available in primary care. So they only saw a doctor once, really just to check that they were happy to do the study and to agree that we could do a remarkable thing on day one, and this is day one, when we asked all our participants to stop their anti-diabetes drugs, all of them, and their antihypertensive and diuretic medications when they're used for treating blood pressure. The reason for that, and Nerys has sort of hinted at this in her presentation, as did Tony Leeds, was that this is for safety reasons. If you then go on to day two, or later on in day one, when they start a total diet replacement program, 830 kilocalories per day, formula diet, nutritionally balanced, perhaps the best, most perfect way of ensuring safety during weight loss. But if you do that with glucose-lowering drugs, there is a risk of hypoglycemia. So we asked them to stop all medications on day one and to monitor blood glucose just using finger prick tests. And that included metformin. All the drugs were stopped. This was also a very big incentive for our patients and motivation to continue. They were very appreciative of the opportunity to be able to manage their diabetes without medication. Similarly, if you were to go on to total diet replacement of this level and continue the antihypertensive or diuretic drugs, then blood pressure can fall rapidly with dizziness, postural hypertension, and even blackouts. So for safety reasons, we asked them to stop the medication, but of course we then monitored the blood pressure and had a protocol for reintroducing the medication if necessary, and in some cases that was necessary. So the total diet replacement was very similar to that you heard about in the other studies, 830 calories a day, balanced for all the nutrients. It was not a particularly high protein diet, I'm pleased to say, because high protein diets are getting bad press for complications now. And we then moved on after 12 weeks approximately to a food reintroduction phase. That 12-week period was flexible, and the reason we did this was because some of our participants did have holidays coming up or weddings or reasons why some days or some groups of days they couldn't actually do the total diet replacement. But we agreed that it was, provided they notched up the equivalent of 12 weeks over 20 weeks, we could allow them to continue in the trial. And during that term, they were seen regularly by a qualified dietitian or a qualified practice nurse with training in the program, who prepared them, and this is very important, during this period when they don't have to think about their food intake at all, they simply take the formula diet, prepare them to reintroduce meals one by one, and then to go on to weight loss maintenance. And I think it'd be fair to say that this food introduction was the most stressful part of the program for our patients. We notionally had a 2-month period to do this. Many of our participants found this difficult. They had to then make decisions, and they couldn't go back to eating in the way that they were eating before they lost weight, because if they did that, then their weights would inevitably return. So we sometimes allowed them a longer periods to introduce meals one by one. They then went on to their weight loss maintenance phase. And this was, again, carefully designed not to be a high carbohydrate or low carbohydrate diet. It was not high or low in anything. It was a very typical nutrient profile, similar to that of the UK, if there is such a thing as the UK, with between 40 and 50% of energy from carbohydrate. Most of our participants elected to go nearer the 50%, but we allowed those who wish to have slightly lower intakes to do so. None of our participants wanted to follow any kind of radical diets in their long-term weight loss maintenance. During that phase, we did also allow them to use one meal replacement a day, a formula meal replacement, the same formula diet as we had used in total diet replacement. And many of the participants did elect to do that to make the weight loss maintenance phase easier. We also allowed or included what we called a rescue plan or relapse management, such that if their weights increased by 2 kilograms during weight loss maintenance, we offered them a 2-week or even 4-week period back on total diet replacement to get them back on train. And many of our participants, about a third of them, did take up that offer at some stage. And it was reassuring for them from the very beginning to know that that was going to be an offer, that they were going to be helped in the weight loss maintenance phase and offered relapse management if necessary. The design of the study was to try to get more than 20% of our patients into remission. And this was considered a very, very radical thing at the time. We as I mentioned, it was doubted whether this was remotely possible. We aimed for 22%. And that was because our public health doctors in the UK said that we would have to then make a change in the strategy for managing type 2 diabetes if this could be achieved at 1 year. So this was a design based on data at 1 year. We were required to get 280 participants. We, in fact, had to close the gates when we got over 300 because this is a very popular study. We assumed there would be a remission rate of about 5% in the control group because some of them would have heard about the possibility of remission with weight loss and probably would go down the road and buy themselves a formula diet to do it themselves. And of course, with the publicity that Michael Mosley and some of his friends gave us, some of our control participants did actually do that, lost weight, and 1 or 2 of them did get remissions as a consequence. The results are fairly well known now, but staggeringly, we exceeded that target of 22%. We more than double the number of remissions of diabetes. So these are people who at 1 year were no longer diabetic. Hemoglobin A1C was below 48 millimoles per mole, 6.5%, which is the WHO criterion for diagnosis. And they had been off all anti-diabetes medication, including metformin, for 12 months in this particular case. So those data alone set in train all sorts of measures across the country to provide services which would gradually move people towards remission of type 2 diabetes. And part of the reason for this is that this is what patients themselves wanted and began to demand as soon as they heard about these results. At 2 years, that remission rate had fallen to 36%, so still well above the target at 1 year, and a remarkable achievement. And the reason became very clear as to why that figure had fallen. I should mention that at 1 year, the weight losses were approximately 10 kilograms below baseline. Their initial weight loss had been somewhere approaching 15 kilograms at 3 months, 4 months, and that's leveled out at about 10 kilograms at 12 months. So half the patients had lost more than 10 kilograms, and a little fewer than half at 2 years. And that decline in the remission rate was entirely because of 15 participants in the intervention group who regained weight, and their weights became closer to baseline than 10 kilograms. So our data really supported the interpretation of John Dixon in his surgical study, which was that if patients lost greater than 10 kilograms, they were very, very likely to be in remission at 2 years. And virtually all the patients who did lose more than 10 kilograms were in remission at 2 years. So our target of 15 kilograms was there to ensure that a substantial number would get to the 10 kilogram point. It's not necessary for all of them to do so. Those remissions are remarkably well sustained. And here's a figure from a more recent paper, which looks at the remission rate according to the weight loss achieved at 1 year in the pale columns and at 2 years in the darker pink columns. On the right-hand side here are the people who lost greater than 15 kilograms. And you can see that for 1 year, if you lost 15 kilograms, 86% were in remission. Nearly 9 out of 10 were free from diabetes, not requiring medication. At 2 years, 82%. So virtually the same figure, very, very highly sustained remissions if people could actually maintain that weight loss. And you can see that for a 10 to 15 kilogram weight loss, the figures are equally well or even better sustained. And the reason for this is, of course, that the people who slipped out of the 15 kilogram category were very close to 15 kilograms in the 10 to 15. And these are not absolute cutoffs, but they give an indication. Remissions are very, very well sustained, provided the weight loss is sustained. For any given weight loss, remissions rates will be sustained for at least 2 years. I mentioned that we stopped the blood pressure and diuretic medications. A lot of doctors, and Nerys mentioned this also, were anxious about this because patients have been on them often for many years, and people assumed that they must be terribly important. The results are shown here. This slide shows just the total diet replacement period, 12 visits up to 20 weeks, and those who got as far as 20 weeks. And the blood pressures are shown here. The white line is people who were never on antihypertensive or diuretic drugs, and their blood pressures fell really very rapidly over the 4 visits. Their blood pressures fell to approximately 10 millimeters of mercury below baseline, and some of them fell extremely rapidly. In the green are the people who had been on one drug for blood pressure, and you can see that their blood pressures also fell to approximately the same level at the end of total diet replacement, 10 millimeters of mercury below baseline. This is an enormous drop, much greater than can be achieved with any drugs for blood pressure. The yellow line is people who had been on 2 or more drugs for their blood pressure, and often these are people who've been on a diuretic plus 1 or 2 other drugs for blood pressure. Their blood pressures, when we stopped them and they went on to total diet replacement, did not change for the first 5 visits, which was up to about 7 or 8 weeks. Thereafter, they fell. And again, that group, their blood pressures were around about 10 millimeters of mercury below baseline. About 30% did require to go back onto medication. That was through monitoring the blood pressure during the trial, and this was done safely. So what we can say is that stopping the medication completely, as people start the total diet replacement, is entirely safe, even for people who were on 2 or more medications for blood pressure, provided the blood pressure is being checked and monitored, and that's often done by the patients themselves and reported back to dietitians or the nurse in the practice, who will then instigate reintroduction of medication if that is necessary. Most of the patients did not require to go back onto medication, and we can say that the effect of total diet replacement for a 12-week period was far greater than any of our medications, drugs that are available to treat blood pressure or diuretics. And I think that's a lesson for all doctors. Nerys mentioned serious adverse events. The minor adverse events that we met in the direct trial were very similar to those which had been mentioned earlier, with a bit of constipation, which was usually resolved with the help of a dietary fiber supplement. We didn't have a lot of dizziness, mainly because we stopped the medications that commonly cause that dizziness. And so the minor events were not actually a problem. We did have some serious adverse events within the 2-year period. And I'm showing here the serious adverse events up to 2 years. Serious adverse events are things which require people to go into hospital, and it would include deaths, although luckily we didn't see too many of them, any of them at this stage. And what we can see is that in the first 12 months, there was no difference between the groups, none at all. However, in the second 12 months, year 2 of the study, there were significantly fewer serious adverse events in the intervention group. That's very unusual for a clinical trial, which are mostly drug trials. We always see more serious adverse events in the intervention group who's given a medication. In this trial, we saw a reduction in serious adverse events, a significant reduction in the second year. It's very early to make any real judgments on this, but it certainly, it is as we would expect from a reduction in blood pressure, reduction in hemoglobin A1C, a reduction in lipids, and also quite a striking improvement in liver function, which we saw in this trial. What were those serious adverse events? Well, in the intervention group, the total diet replacement and maintenance group, we had one patient who had coronary artery disease and a non-fatal myocardial infarction. In the control group, you can see there's a list of complications here, which include deaths, strokes, aneurysms, amputations, and 5 cancers. So these are all conditions which are more common in people with type 2 diabetes and which we would expect to be reduced if there is no diabetes. This is very much in line with our old Aberdeen study, which suggested that people might live same life expectancies if we can get rid of their diabetes. Very early days, but quite exciting data. So in summary, the results from the direct trial, the intervention group had a lower hemoglobin A1C with fewer of the patients on medications. There was a lower blood pressure across the board with fewer requiring medication and less medication when they did need it. The Q risk was halved in this study, enormous reduction in Q risk. And the reason for that was that these patients were half of them were no longer diabetic at 1 year, and about just over a third no longer diabetic at 2 years. And that is a major factor for the risk of a cardiovascular event. Tony, I think Nerys also mentioned that we have done very detailed health economic analysis here. There was a reduction in the number of medications used both for their diabetes, for their blood pressure, and other medications which were required less with the intervention. Many other things like painkillers were less often required, even sleeping tablets were less often required in patients who lost a lot of weight. They had fewer serious adverse events and admissions to hospital, fewer referrals to hospital, or either to see doctors or outpatient clinics or to see dietitians or physiotherapists, fewer consultations for hospital. So much lower costs in the intervention group. And quality of life, I've put in sort of yellow here because losing 10 or 15 kilograms in weight really does improve quality of life. Very significant. We had a huge improvement in quality of life. And I think the message here is that whilst losing weight with a dietitian to lose 5 kilograms in weight, which people do, it's hard work. Quality of life, you don't look different, you don't really feel terribly different. 5 kilograms isn't going to do it for you, but lose 10 or 15 kilograms, and that makes a huge difference. I'm not going to try and explain to you the details of this health economics analysis here, but I can just jump to the conclusions of it, and all the data are in the published paper. And that is that we would predict from all the data very similar to those which you heard from Nerys, but perhaps more striking because people with type 2 diabetes have got far worse long-term health outlooks than people they were studying in the droplet trial. They would live longer, they would feel better, and they would cost less. So it's a sort of win-win-win situation. And it really begs the question why one would not offer this management program in primary care. The break-even point was at about 5 years. So the upfront costs of setting up the trial or setting up a service and the costs of providing a total diet replacement service, which are similar in this to the ones in droplet, are counterbalanced by savings from all the other things. And that the break-even point is at about just beyond 5 years. What we're doing now, and I was asked to talk a little bit about sort of rollout and where we're going next with all this. Firstly, the program that we used in this particular study was Counterweight Plus, which was the diet program that we developed as a spin-out company from university doctors, and I was advisor to that program. I'm not involved in the company now that it's an independent commercial company. It provided this service that we showed you in direct. During the COVID year, one of the very few things which has come out of it as a benefit is that they were forced to deliver the entire service remotely. So no face-to-face dietetic consultations or nurse consultations. The total diet replacement is now delivered directly to people in their homes, and the support is given using all the available means of IT with emails and Zooms and WhatsApp. And goodness, we've actually rediscovered the telephone, which I also have to mention was discovered and was invented by a Scotsman many years ago. And these data just show here what is being achieved in, not in the clinical trial, but in the people who are accessing the same program, about half of them with type 2 diabetes across the country. And you can see that after 12 weeks of total diet replacement, their weight loss is 15 kilograms on average, over 100 people in this audit. At 12 months, about half of them have reached the 12-month period. And at 12 months, the average weight loss is 15.8 kilograms. So the weight loss is actually being maintained even better using remote delivery, delivered to people in their own homes, than we were doing with face-to-face delivery in primary care. So this is one of the small benefits which seems to have climbed out of COVID. Now, I mentioned that a subset of our patients were followed up in Newcastle by Roy Taylor. These data have all been published. They're quite exciting. And what they say is, firstly, that people with type 2 diabetes have a very large amount of fat in their liver. They have a large amount of fat within the abdomen. They have big waists in general. And the liver fat is strikingly increased. And that falls with weight loss in the patients who are in remission. It falls dramatically to normal. That did not happen in the patients, that's in the blue column, that did not happen in the patients in the greenish column who did not get remissions. Their liver fat remained high. And it did not happen in the patient who had relapses at 2 years. And these are the data from 2 years. With the fall in liver fat, there was also a fall in the VLDL, which is the fat being taken out of the liver and transported around the body in the bloodstream. That also fell with remission. And you can see that it actually didn't fall, it actually increased in the people who were who had relapses. So people who went back into diabetes, circulating fat went up. And this effect of circulating blood fats from the liver, the lipids in the blood, was that patients with type 2 diabetes at baseline had fatty tests, and with remission, the fat in the pancreas was removed to become normal. That did not happen when there was no remission, and it didn't happen when there was a relapse. Now I can show this in even more detail now. A more recent paper which has images of the pancreas. On the right-hand column are data from patients with no diabetes, never had diabetes. And that's an MRI scan of a normal pancreas. And it shows the volume, its shape, and its insulin production. So a patient with type 2 diabetes at baseline on the left has a very ragged, sick-looking pancreas. It has low volume. It has a very ragged surface. And the insulin secretion, this pancreas is not able to make a normal amount of insulin, less than half the normal amount of insulin. And you can see that as these patients went into remission, very gradually, over 2 years, there was a steady increase in the capacity of the pancreas to make insulin, and it became normal. 2 years, the pancreas was making a normal amount of insulin under maximum stimulation. And the shape of the pancreas at 2 years was really indistinguishable from a normal pancreas. There'd been a full recovery of the morphology of the pancreas. So, DIRECT trial is telling us something, or confirming something very fundamental about what happens when people put on weight. And I think what we've got here is a situation where about, in Western populations, or North American population, European, about 60% of people, and you may be lucky yourself or you may not be, but if you're in that 60%, you can gain weight and you may get complications like arthritis or indigestion or other things, but you will probably not get a lot of them if you're in that 60%. You'll get some increase in heart disease, but not a lot. However, about 40% of all people listening to this talk, all people across our population have the predisposition, genetic, epigenetic, for metabolic syndrome. We know some of the genes, we don't know them all yet. But if those people, about 40% of all people, gain weight, at some stage they will start putting fat, ectopic fat, into the liver, into the pancreas, into the heart, and they will get horrible complications, which are irreversible. So once you've had a heart attack, or you've got a microvascular disease and you're blind, or you've lost your kidneys, that's a bit too late. However, what we've done in DIRECT is show something very simple, is that at least at an early stage, we can reverse that. We can lose weight and we can get rid of that ectopic fat. And if we extrapolate on to our old Aberdeen study, it looks possible that we can then avoid the long-term complications. You can't get complications of a disease if you haven't got the disease. So these people no longer have diabetes. To finish up with, I'll just show you very, very quickly a new systematic review that we've done of all the clinical trials and studies, not just clinical trials, which have looked at remission of type 2 diabetes. It's a new sort of buzzword. It's a very new word, and it wasn't understood by doctors until about 3 years ago. Now, I think pretty much every doctor in this country is talking about remission of type 2 diabetes as an important target. So I told you about DIRECT. A very similar study called TDMR was conducted in Qatar, and a slightly smaller study with essentially the same protocol, very good weight loss, 12% at 1 year. These are 1 year data. And using an intention to treat analysis, they got a 61% remission rate, tremendous remission rate, even better than in DIRECT, but a remission rate of 12% in the control group. And the reason for that was that with usual care in the control group, these are slightly younger people with more recent onset diabetes, only up to 2 years from diagnosis. And also, of course, they had the confidence of knowing the results of DIRECT, that this was highly likely to be successful, but very strong confirmatory data. Several other studies, and they're shown here, have looked at low-carb diets. And there's sort of a bandwagon effect here that many groups have said, oh, well, we'll look at our data retrospectively and see what we got in terms of remissions. There was a study conducted by the Virta Health Group, in a big commercial company in the United States, which promotes low-carb diets, ketogenic diets. They have very good weight loss, 13.8 kilograms, but a very poor remission rate. So the low-carb diet is not providing the solutions that patients need here. This figure, I'll qualify it, there may have been slightly more remissions than they were able to demonstrate because they didn't stop the medications to be completely sure that whether they'd got remissions in all the other participants. This was not a randomized controlled trial, so it only took the sort of best people who were willing to continue with the trial. David Unwin, as a GP in England, he did a remarkable study in his practice. He asked every patient with diabetes, 473 of them, to go onto a ketogenic diet. Across the board, he got a remission rate of 12.5%, which is really excellent at 2 years. Of course, a lot of the patients, most of them were not happy to do that. But those who stuck on that diet, over 100, they got a 46% remission rate of diabetes. Very remarkable. Other studies have had much less successful results. And I just mentioned at the bottom here, the look-ahead trial, biggest ever trial conducted in type 2 diabetes, was not designed to get remissions, but it did have an 8.6% weight loss in a group of patients who with much longer duration disease, and they had remissions of 11%. So the pattern here is very consistent. The more weight loss you can get up to and above 10 and 15% will give remissions very reliably, but you need to start as early as possible. If you leave this until diabetes has been there for several years, you're going to miss the boat. Rolling out this program, very quickly, Diabetes UK put together a paper called the DIRECT Principles paper, which sets out the principles within the intervention program that ought to be able to produce remissions when delivered in other settings. So there's nothing magical about the program that we used. The formula diet was certainly not magical. The program, the educational program, Counterweight Plus, we had spent the best part of 10 years developing and evaluating. Other people will do something similar, and we hope that they will be successful. What is happening now in the UK is there's this very rapid understanding that remission of diabetes is possible, and the patients are jumping up to their doctors and saying, come on, we want this. In Scotland, every health board is now able to deliver and has trained staff to deliver the Counterweight Plus programme. So the decision in Scotland was to go with the evidence-based programme, the one that works and has been shown to work, with the the support programme that has gone into it. And the training is not onerous, but I say it's now available on every single health board across the country. In England, a pilot study has been set up of 5,000 people, but using other diets, a variety of diets, which are sort of lookalike diets of one kind or another. And we have yet to see how successful they will be. And I've listed here a number of other programs across the world, which I'm involved with. So there's a study in Europe, which is doing a direct comparison between a total diet replacement and low carb diet program. Very difficult to do, but we've got one planned up and just needing funding to do it now. And it's already funded in some countries, but not yet in the UK. I'm involved in 3 evaluated programs using total diet replacement in Australia. One of them is using Counterweight Plus, another using, I think it's a Nestle product, but there's no magic in that. In New Zealand, Pricewaterhouse has done a huge evaluation of diabetes as it affects the economy and health services. And not surprising, they have now recommended the use of total diet replacement as routine treatment. That has gone to government, and decisions will hopefully come down. They make good decisions in New Zealand, by and large. I'm involved in a program in Nepal, where formula diets are simply not an option because ordinary people do not have sufficient money to pay for this sort of thing. So we've had to develop food-based approaches. And similarly, in India, where diabetes is so common in poorer communities, and we're trying to put these 2 programs together. And then there's programs in the United States, and there are many of them. I'm just involved in one. So there's a lot going on. This slide shows Scottish food-based approach, which is called the No Doubts diet. It's a bit of fun, but it actually works, and that is to have a bowl of porridge in the morning, a bowl of lentil soup at lunchtime, and then another bowl of soup at dinner time, but different lentil soup and a piece of fruit with each one. 830 calories a day, 850. And in Nepal, again, traditional diets. So the message here is that if we can adapt traditional diets, we can approach the same sort of 830, 850 calories a day for weight loss induction, and then move gently on to maintenance using traditional food stuff. So here are the summaries. We must treat type 2 diabetes and obesity, the disease process, much more seriously than we have in the past. Type 2 diabetes is at least as serious as some major cancers, and we need to treat the treatment as seriously as we would chemotherapy. We have an optimal diet program in terms of Counterweight Plus, which is well evaluated. We have the principles which can be applied elsewhere and evaluated. And we should, I think, be targeting 15 kilograms weight loss in Europeans, certainly, with the aim of getting the maximum number past the 10 kilogram cutoff. In Asians, it's possible because they start at a lower weight and have different body build, that we may be able to get by with a 10 kilogram weight loss. And we have a pilot study looking at that at the moment. But the big issue is long-term weight loss maintenance. I'm sure that's where our discussions will take us. So a huge thank you to everybody involved in the direct trial, particularly to the foresight of Diabetes UK charity on behalf of people with diabetes. Thank you very much.
Thank you. Thank you very much, Mike. There are a number of questions have come up during the course of the day, and one of them related to the question of whether adaptation of resting metabolic rate was one of the reasons why maintenance of weight was difficult and why weight regain occurs. Obviously, there are several factors. Do you want to comment on that, Mike? And then I'll ask Nerys for a comment on that.
Yes,
is the adaptation that takes place important?
Well, it happens. I think it's not the most important factor. When people lose 10 or 15% of body weight, their basal metabolic rate is going to fall by something in the region of 8 to 10%. It isn't a massive fall. It would add up to, let me think, that would be about 10%, about a couple of 100 to 300 calories a day that they would have to undereat in order to maintain weight at a lower level. And that then brings them in line with people who were always at that level. So it's bringing people's calorie intakes down to the level of somebody at whatever weight they end up. But the reason that people stop losing weight is that it's jolly hard to do it. You know, to undereat and keep undereating, to be losing weight, sets up a whole lot of physiological and also, I think, psychological factors. And just the fact that people, down the street will say, "Oh gosh, you've lost a lot of weight," and start to query whether that's a good thing or not. Very mind of some patients.
Nerys, do you want to comment?
Yeah, I think there's a couple of important concepts. So when, the first one is that fat or adipose tissue is quite a metabolically active tissue. So people who have quite a substantial BMI have a lot of fat. And we know that when you lose weight, the other concept is you lose body fat, but you also lose lean tissue. And that's not something to worry about. It's what happens when you lose weight. So you'll lose approximately 80% will be body fat, and the other 20% will be lean tissues. That's not all muscle. It's things like muscle, organ mass, and extracellular tissue, as the person said. So your BMR will be reduced because you are losing metabolically active tissues in terms of the lean, but also in terms of the body fat. When you lose a lot of body fat, that adds up, even though it's less metabolically active than the lean tissue. And I agree with Mike, I don't think it's what's driving people to not stick with diets. It's the fact that they're unable to keep to the low energy for long periods of time.
Yeah, I think it's really important, Tony, to emphasize what Nerys has said there, which is that when people lose weight, they have to lose lean tissue. In terms of the supporting tissue that goes with the body fat. I mean, the body fat is sitting there, but it is supported by connective tissue, by vascular tissue. You have to have a bigger heart to push the blood around all the extra fat. So when people lose weight on purpose, they're going to lose fat, mostly it'll be fat, but there will always be a loss of some lean tissue, and that's not something to worry about. It often gets a bit confused with the studies which have aimed to try to show that you can lose weight without losing lean tissue. That is a misunderstanding. There will always be loss of lean tissue. You can boost the lean tissue by physical activity, and perhaps the Look Ahead trial was one of the best to show this, which is that if people lose weight without any physical activity, then they will lose a fair amount of lean tissue. But if they maintain a steady physical activity program, then you can lose weight with minimal loss of lean tissue. I didn't mention it in direct. We purposely did not ask people to increase physical activity during the weight loss phase, but we did ask them to maintain their usual levels of physical activity. And that's enough to maintain the muscle mass. It doesn't, giving more dietary protein doesn't make you grow more muscle. That's something.
Yeah, I think the other important thing is there's no evidence that TDR disproportionately lose lean tissue. It's just, as Mike said, it's what happens when you lose weight.
Let's just cover a couple more questions and then we need to close. There is a comment on the system here, which is directed at Nerys. You wanted to answer the question about products.
Yes, so I think Lorena is asking, are there any products for TDR that are commercial meal replacements or any ones that we can use? So at the present time, the different regulations for things that can be used, products that can be used as a total diet replacement and products that can be used as a partial meal replacement. So that is, you have some with some food. If I direct you to the primary care website, we've got some resources. If you are a patient, how you can access them. There are additional providers who provide to the NHS or any diabetes prevention programs, but the main providers that you can access as a patient are available on that website.
Yeah, thank you. And then there was a comment there about legislation, which we'll answer by email explaining what the legislation changes are going to be. Any final comments from either of you, Mike? Nerys, do you want to make any final?
One of the other questions was
yes.
about hydration, and
yes.
in fact, there's a lot of these people do actually carry excess body water. They have edema, and many quite seriously obese people have really quite a bit of dependent edema. The legs, and you can't see it because there's not usually so much body fat there. But that comment is quite right. That will be picked up as loss of lean tissue because it's water, and so a source of misunderstanding in the data. Yeah.
Nerys, any final comment?
No, I don't think
so. That's great. Well, can I thank you both very much, and of course thanks to Jennie in Sydney as well for your participation. This is we had nearly 100 people attending, and also these recordings will be available afterwards, so people will be able to access them. They have the abstracts and they have the references and so on, so that's great. So thank you very much indeed for participating. but also thank you to the Secretariat for organising this, and also to you, the delegates, for your participation. I'm just checking there are no final questions that have appeared, but we will circulate the slides, and if you haven't had the abstracts, we can send those to you again. And these will be on the our website, TDMR Europe website, on a weekly basis. We'll put them up on a weekly basis. So thank you very much. I think that's been great. We've had some really, really good summaries of the studies that have been done, and look forward to talking to you all again in due course. Thank you very much indeed.